I'm Dr. Craig Escudé, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
The IDD Health Matters podcast is a joint production between Friends for Life and IntellectAbility. For more information, go down into the show notes and click the link where it says Learn More Here.
So welcome to this episode of IDD Health Matters. Our guest today is Cathy Service.
Correct.
Cathy, tell us about what you do in this field.
Okay, Craig, what I do, I'm a nurse practitioner, and I have been working in the field since 1976, and I've been a nurse practitioner since 1978. Most of my work as an NP has been with people who have intellectual disabilities, and I started out at a state institution and did what you typically think of being nurse practitioner in the expanded role, in the role of like the physician at the state school. And then as it was closing, I knew at the time I needed to continue to work for the state, which I liked, and I really, really appreciated. I liked the field, which I got into accidentally because back in 76, I had been doing med-surg nursing, and we moved back to where I grew up. So my first husband could go to school, and the only place I could get a full-time job was at Belchertown State School.
So is that kind of how you got your introduction into this field?
Yeah, although quite honestly, my mother had a brother with an intellectual disability who was in an institution, and we would get cards from him growing up. And he had a really kids' penmanship, and he had bad seizures. And he always wanted to come. I grew up on a farm. He wanted to come to the farm and see us, but my parents were afraid with the girls and things, so I never met him. And sadly, I found out I was doing a EMT course at the state school at the time, and I found out that he had left the other institution because we kind of trained together, and he was in a group home nearby. So I convinced my mother, let's find Uncle Junior, that's what we used to call him. And she hadn't seen him for years because she didn't drive, and her sister would take them, and then she and her sister got in a fight, and so the usual family dynamic.
We all have.
Yeah. So she didn't keep track with him, and we were making plans. I kind of found out which group home, and unfortunately, he died before we were able to get there. So I always think, I missed an opportunity, but in a way, his legacy kind of lives on because I have a good friend who's I always think of him looking for Uncle Junior, my friend. So
nice. So Cathy, you mentioned living in an institution, and you've been in the field long enough to have experienced this movement from institutional, supports and services to more community-based supports and services. What were some of the challenges that you saw, particularly relating to health, as people moved more into community settings?
Well, when people are in an institution, it's really, you have a captive audience. And at the time when I started, the position I had was because of the substandard care people were getting in an institution. So we had gotten sued, and money became available for advanced practice nurses, and really the NPs, and we had some PAs too, really did all the work medically. And once you move out, it was great in terms of socially, et cetera. However, the medical care was difficult. And, the issue, when I first moved out, we organized and opened a bunch of state-run residential programs. So I kind of helped to coordinate getting people to care in the community, and there were nurses, and at the time there were ICF, so they had a lot more clinical supports. There were some staff departments, as we called them, but most of them were, run by the state. So they had a lot, staff were paid and things like that. So the people were getting a lot, and there were a lot of different kinds of resources as compared to group homes outside the system. People weren't paid as well. They didn't have a lot of resources. And back then, the staff were doing the meds without even being trained out in these homes.
So, what you mentioned, the captive audience situation, I know what you mean by that. And then the change, let's just say, in the level of healthcare when people moved into community settings is something that I do talk about and think about, and kind of spurred some of what what got me to where I am now. And when that happened where I was, as people were moving into community settings, what I had realized was, people at these facilities actually got really good health care.
Honest to goodness.
Really good health care.
I agree with you, Craig. I mean, I couldn't believe I was an NP. I'd see people for little cuts and whatever. It was amazing.
Yeah.
It really was.
Access was there, readily available, in these institutions. Again, there's a lot of negatives to that as well, too. But from a medical standpoint, they had access to clinicians who had experience most of the time.
At that time frame.
Right, in that time frame. And then as people moved into community settings, what concerned me was I knew that they were going to be then receiving health care from community-based clinicians who had the same training that I did, which was zero. In this field. And that was a big concern and a motivator for me to start providing training and education to clinicians. That you probably do some things in that area too.
No, I mean, a lot of it also, I do a lot of training, but a lot of it when I go on, sometimes I used to go on the medical appointments, and I would do a lot of, on the spot education of people. But the other thing that I did is because the way that, fast forward a little bit, after we opened those group homes, a position became available in our area. What happened is that they had every area office, and most places are kind of organized geographically. So in my area, and it was great because I lived and worked in where I was practicing, and so one of the other things I did is that I became really active in a lot of community settings. I'm on the hospital ethics committee, for instance. I end up doing a lot of work at the senior centers. I volunteer for a lot of organizations in the community. So I'm there, and I can talk to people like our elder service. I mean, the area agency on aging. I'm on their board of directors, so I bring things out, and I do it in that way where we can kind of partner with people.
And speaking of aging, because of improvements, people with intellectual and developmental disabilities are living longer.
Correct.
And so they get to enjoy some of the things that we all get to enjoy as we get older, including arthritis and vision changes and hearing changes and dementia.
Correct.
And you do a lot of work in
that. Yes, I do. And part of it is that my master's degree is in gerontological nursing. So my master's I started to study. I got a studentship to get my PhD in Newcastle. However, that didn't come to pass because of personal things. But my research was going to be on risk perception of older people with intellectual disabilities and the relevancy of their social networks. So, but in the meantime, back in 95, when I was out in the community, we were noticing people were developing dementia. And, I thought I knew something about dementia, but I didn't. So I became I went to Boston to the Alzheimer's Association, was trained as a trainer, and then I got kind of connected with the experts in dementia and intellectual disabilities, Art Dalton and Matt Janicki, and I've done a lot of work with them over the years. Matt's a friend of mine, and
I bet you know Dr. Seth Keller.
I sure do. Yeah, we are on the board of the National Task Group on Intellectual Disabilities and Dementia Practices. So, but I do a lot of work with dementia, and it's fascinating. But I'm always educating people. In fact, the Alzheimer's Association in Massachusetts connects with me. I'm now on their Diversity and Inclusion Committee to represent people with ID, but it's also more medically. After I retired in 2016, and I got involved with a couple of federal grants on caregiving and dementia. And then I was hired as a consultant through the Department of Developmental Services to provide, consultation on people who are living with dementia and have intellectual disabilities. So
I'm going to pick your brain.
Sure.
what are a couple of things that might be unusual or different signs of dementia in people with intellectual and developmental disabilities?
Different signs. Well, everybody is different. And the thing, and Seth and a number of people know, everybody has a baseline that's unique. And it has to be a change from the baseline. So there you're saying it's different. You don't know because you have to get to know the person. So when I go in, it's getting a life story, getting a life history, looking over, all the medical records. And, based upon what I know about risk factors with dementia, that will make me to kind of look into a lot of things. Like, for instance, early on, I was asked to consult on a gentleman who didn't have Down syndrome. And I have to admit that Down syndrome, it's difficult, but it's a lot easier. There's a lot of literature, there's a lot of research done, so I feel pretty comfortable.
And because people with Down syndrome have a much higher incidence of developing dementia and earlier.
Correct.
Earlier on,
yeah.
right?
Yeah. That's at younger ages, which makes it difficult in terms of supports. And one of the other things that I do with regards to dementia care is I facilitate an online support group for families who have somebody who is living with dementia, and most of them, up until a couple months ago, have Alzheimer's disease, and Down syndrome.
And that's really valuable and important, because one of the things that we don't often think about is the support that is needed for the people that are providing support for the person which has dementia, because it can be very taxing.
It's hard. It is hard. I agree. And I think, even though I was doing a lot of assessments, and it was that one I was just going to start to talk about was a man who turned out to have really severe visual impairments. He was nonverbal. And long story short, while he was having some changes in his ADLs, turned out his eyes were really bad, and he was depressed. His sister, after I spent a lot of time, I talked to his sister, and there's a strong family history of depression. So, and I can make recommendations, but in my consultant role, I don't write orders, but
sure.
It's up to somebody else. So that was an interesting one for me to kind of follow through on, and I really have to just kind of send a shout out to Dr. Julie Moran, who's a geriatrician I work with through the state, and she's done a lot of work on assessing, and then people who are older and typically may have dementia. So, but now I'm more involved with post-diagnostic support. So I do a lot of work around supporting people, whether it's in their homes, whether it's doing with a lot of direct support professionals, and we'll have meetings, and I'll get to understand what's important to people, and having that life story. And it is fascinating, and there's nuances. The other thing that I'm interested in, because I'm working on a grant through the University of Illinois Chicago, CDC has a Healthy Brain Initiative, so looking at risk factors across the lifespan. So, and one of the things that I'm concerned that even when you're living with dementia, your well-being is essential. And so what kinds of things that go into making people feel as well as they can. And also, we want to nourish those brain cells that are there. So, that's like, I'm doing a lot of discussion with that, with staff about that. And so going even to terms of going across the lifespan. And it's fascinating. I did a talk at the DDNA, the pre-con on aging. And in my research for the talk, I looked a lot into social determinants of health, and there's a lot of work being done on stress and what happens over a lifetime of stress. So I keep thinking about many of these people, especially if they've been in institutions or haven't had a lot of access to supports, that they may have these what they call almost like microaggressions or abrasion that can kind of what it does is shorten their telomeres and makes them at higher risk for aging earlier, and also for a lot more conditions after that.
I want to make sure I heard what you said. So stress in our lives can actually shorten some of our physical things in our brain, right?
Yeah, and not be able to, when you have stressors, you aren't able to manage further insults because you're just not at a good basic point. And you're not able to bounce back. In fact, Carl Tyler, who's another geriatrician that I've worked with.
Carl.
Yeah, he's great. He and I did one of the editions at the chapter, Leslie Rubin and Alan Crocker's text. And he taught me the term homeostenosis, which is almost means that, your bounce backness when you get older isn't as flexible. And sometimes people don't bounce back.
And, when we think about that, we know as we get older, we get from the same amount of work we used to do 20 years ago, we're a lot slower to recover from
exactly.
that. And the same thing can happen with our
Well, I know it is that. And, what's normal aging and trying to figure out. In fact, that can be really complex with people about, is this okay? Is there something pathological going on? I mean, the good thing, you can make diagnosis, but a lot of things are over time. You have to really do a careful assessment, and it's biopsychosocial and ecological. That's how you have to take the big picture.
All the pieces together,
Yeah.
absolutely.
Yeah.
We talk about we're talking about dementia, which is often something that we see cognitively in people, and then we're talking about how do we diagnose that in people who maybe don't communicate with words, and you can't necessarily detect the difference in cognition.
Yeah.
So
you look at things, function, behaviors. All behavior is communication. That's the key.
I say that all the time. That's
all
right.
the time.
Yeah.
The other thing I was going to say about behavior. Yeah. So that's part of it, and also terminology. I mean, I'm really cognizant because dementia in itself is stigmatizing, and with people with intellectual disabilities, it's stigmatizing. So they're double stigmatized. So I always use the term living with dementia because people are living with dementia until they die. So how do we make them to have a worthy life? And then the other thing in our field is the term behaviors. It has such a negative connotation that I try to use, and it's kind of hard because it gets awkward, using either behavior distress or behavior expression. So I try to use that, the change.
I like
behavior.
those terms. Can I borrow those?
Use it fine. They're fine.
Behavior distress.
Or behavior expression. Yeah,
like
yeah.
that.
But I think that's a key thing to talk to people about. And, I will use a lot of other frameworks, if you want to say, when I'm working with, direct support professionals or people in our field. And one thing is for sure is that people that we work with have a lot of skill sets. For sure. For instance, one of the things, we do a lot of talk when you see something happening is that, well, what does this behavior, what do you see? What does it mean? And you go back to the same old ABC, the things that when direct support professionals are looking to, in terms of assessing somebody, helping either the clinicians, whatever, they start to look at antecedent behavior, what do you see, blah, 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 writing down the facts.
What happened
before
that might have caused.
Yeah, what happened then. And usually the consequence, the C part, it's a little different when you're working with people with dementia. And when I talk about behavior modification, when somebody is living with dementia, it's at some point you really can't modify their behaviors. So what you need to modify is your behavior.
Very, very important point.
Yeah.
Yes.
So
exactly.
But and I mean, I use myself as an example. I'm a little. I don't know if you can tell by my voice. I'm kind of hyper. So, when I meet somebody who's living in dementia, I'm like, okay, get your Academy Award performance. And I tell direct support people that at team meetings and families, I have to tell myself to pause and be with the moment with the person and how to be with them. And it's also important because I think for direct support professionals and people, how do you write goals? What's the goal for somebody who's living with dementia?
Good question.
Yeah. Well, I really think a sense of well-being and contentedness is important. We're so into doing in this culture that I just think we're not into human doing, we're into human being and being with people. And then trying to figure out, if you're writing goals, how do you write a goal in terms of can the person is at ease within themselves as much as you can be. And
those are all wonderful things to think about and that we should all keep in mind for everyone.
Well, it is. And, people there's some rich moments. Not to say that it's easy. I mean, it isn't. I mean, my mother had lived with dementia, so I know it from that view. But I've been taught a lot, and I tell people this over the years that when I do training is that you all have been my best teachers. So what you tell me, I kind of listen to and try to figure out, and then it's a legacy. I mean, I have a painting that back in '95, one of the first women that when we opened up one of our state ops, had moved in because her older mother, just down the line, you want to say, she moved her into the home, and she had Down syndrome and was developing dementia. And I'm telling you, I learned a lot from that situation, because the mom kept saying, well, what if it's this and what if it's that? And, we were almost convinced, she's got Alzheimer's disease. But we kind of looked at all the differential diagnosis and the rule-outs, which we should do in a good dementia assessment. Because, first of all, and I tell this to even when I'm at the senior center, it's like, don't be afraid to go and get assessed, because there are so many things that look like and seem like dementia, but they may be easily corrected. So that's the other thing.
Yes.
Friends for Life Residential Care, specializing in support for individuals with developmental disabilities, offers services like adult day support and home health care. Emphasizing empowerment and quality of life, we live by the motto, my ability is stronger than my disability. We are currently hiring, welcoming those passionate about making a difference. Learn more and explore career opportunities at friendsforliferc.com.
I'm Dr. Craig Escudé, President of IntellectAbility. State developmental disability agencies, managed care organizations, and providers across the United States use IntellectAbility's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support. So there's something I kind of like to do here. I like to ask guests to tell us 3 things in 3 minutes that you think people who are listening can either get involved with or do, or that things that need to happen in your view to improve overall health, wellness, support services for people with intellectual and developmental disabilities.
Okay.
So,
well, a couple things is, regarding, because my area of interest is aging and dementia care, is learning as much as you can about what it's like to get old, and also like what is dementia and what is care for people who are living with dementia, and how do you come to terms with that within your own practice setting.
So kind of self-education.
Yeah, education's important. Education is really important, and how we and also so you learn all of those kinds of strategies, if I want to say, and realizing too that everybody is unique. As a matter of fact, I was going to entitle my dissertation paper "Ordinary and Extraordinary," because people, and it's ordinary. Most people are ordinary, and there's so many people out there. I know myself from living in my community that there are a lot of people that I see that I know were at the state school at where I live, and but they're ordinary. It's just living life, but they really are extraordinary with what they've done in their life.
Recognizing the extraordinariness of the ordinary.
But it is. There's something about that and to honor that and to be aware of that and then the other thing, and which is great, I guess I'm really blessed, is I'm out there and with people, and I'm laughing because when I was going to my cheap gym, and I'll see some people from some of the, obviously recognizing people, but I always kind of make a point of when I'm there, anyone in the community is welcoming, making people feel comfortable when they're in community settings and whatnot. For instance, even in the senior center, there's some people who come in and who I know who have intellectual disabilities, and sometimes people know me there, and they'll say, "Oh, would you go over and chat with this man or this person?" And I'm a role
something
model.
that everyone can do.
Exactly. And you have to be a role model for people. And you also have to realize, I think, for everybody is that not as everybody is comfortable. And people come from different backgrounds and different age cohorts. You know, I mean, my mom was friends with, I have that man who I'm friends with, and she would, she's almost like treating him like a little kid. And I'm like, Ma, but, that was what she knew at the time. But, I'm always with myself and trying to be a role model in how I interact with him. But it was important in including people in normally occurring activities.
So educating yourself, being a role model for others to follow, and being welcoming. And I think that's, we can all be welcoming.
Well, I think it doesn't require a lot of intensive. I mean, that's the thing, and because people are out there, and I think kindness is the key here, to be kind and welcoming.
Yeah, good advice for all of us. Cathy, this was great. It was really enjoyable, and to hear your insights and thoughts and experiences and the impact that you've had on countless lives in the work that you've done. Thank you for joining us.
Well, thank you, Craig, for asking me.
Absolutely. And thank you for all the work you've done.
Oh, God. Thanks so much. I'm blessed and honored, really, seriously.